Hi everyone! We are here today to discuss our research proposal on characterizing interpersonal difficult situations and mode use in telehealth occupational therapy sessions. To begin, we'll start with a run-through of our research purpose and the study background. The use of telehealth in the delivery of occupational therapy services allows for increased access to care for underserved families and bridges a gap in service delivery to those living at a distance. Telehealth has been proven to be especially beneficial in providing support to families raising children with autism spectrum disorder or ASD. One critical component of the therapist-client relationship is the establishment of therapeutic rapport. Therapists' use of therapeutic rapport and interpersonal skills contribute to client participation and maximizes quality of services delivered. The intentional relationship model, or IRM, explores an occupational therapist's therapeutic use of self in service delivery. The IRM describes a process for critical reflection on self-appraisal, flexibility in communication, and use of interpersonal skills for occupational therapists. There are 6 modes for therapeutic communication defined by the model. There's advocating, collaborating, empathizing, instructing, encouraging, and problem solving. However, client characteristics and interpersonal events unfolding during telehealth sessions among occupational therapists has not yet been researched. Therefore, the purpose of this study is to investigate how client characteristics and interpersonal events unfold during the telehealth sessions among occupational therapists and parents of children with ASD. Participation in telehealth services has been found to have a variety of positive influences, as supported by the research literature highlighted in this slide. Our research proposal provides more in-depth commentary on specific studies that support each of the points listed, but here are some key parts. Telehealth supports the development of a bidirectional relationship between the therapist and client. This allows for parents to feel empowered and improve successful therapeutic interactions. Telehealth also allows for therapy to take place in the naturally occurring family routine and environment of the client. Creating goals that take into account family dynamics increases the parent's involvement in care planning and invites them into having an active role in the client-provider relationship. Telehealth allows for service delivery to underserved populations that might not otherwise have access to care. For example, in a study by Johnson, Kerslake, and Crooks, researchers explored how telehealth therapy services were of large value to rural-based clients who would otherwise be limited in their healthcare access. By taking out the barrier of transportation to appointments, clients were able to speak to their doctors without the cost and hassle of travel. Clients further noted that they felt it was possible to connect and build a therapeutic relationship through these telehealth services. Another positive of telehealth is that the platform allows for multidisciplinary team promotion. Telehealth can create a more seamless and collaborative team treatment approach among providers and the parent of a child with ASD by removing the barrier of location and easing the scheduling planning process. Telehealth has been shown to increase parents' intervention skills, competencies, and overall self-efficacy. Little, Pope, Wallish, and Dunn noted that increases in parental resources and skills such as these are important because they lead to better outcomes for children. A few of these outcomes include increased participation in daily activities and improvements in parent-identified goals. Finally, telehealth has also been found to strengthen the parent-child relationship. Telehealth sessions call for increased communication between parents and children, which therefore lead to increased quality and overall number of interactions between the two. Telehealth has been reported as a successful intervention tool for children with ASD, demonstrated via parent satisfaction reporting, the growth of relationship between parent and child, and a positive reciprocal parent-therapist relationship. However, it is important to explore possible limitations in telehealth to take a fully holistic approach to what telehealth entails. One restraint is the limited financial reimbursement involved in telehealth. Although many insurance companies will cover these services, fragmentations do exist, such as in Medicare coverage. A second challenge in telehealth involves the perceived clinical barriers that present with the lack of face-to-face interaction. With a remote distance between the two, a client may have a harder time building trust and rapport with their practitioner. The client may also question the validity and reliability of the practitioner's services, and a surface-level relationship could develop, impeding quality of care and the intervention use. Prior to telehealth use, a comfort level with the technology involved should be established with the client. Those with limited technology access or exposure may not feel comfortable or fully understand the technology requirements needed for telehealth participation. Finally, healthcare providers noted a fear that telehealth could replace human resources, thus rendering them from choosing to provide these services to their patients. It's important to note that due to the lack of sufficient research in telehealth, many of the drawbacks come from single studies. This makes the aim of our research project even more critical for expanding the current literature. So next, we will discuss the participants for our research study. Our participants included families of children diagnosed with autism spectrum disorder between the ages of 2 and 7 who participated in occupational therapy telehealth intervention services. 4 different occupational therapists were involved in service delivery and will be included in our data analysis. All video sessions under analysis are pre-recorded. We only included videos of participants who were able to complete the intervention and excluded videos with any technical difficulties like those recorded without sound. We plan to gather additional demographic information on clients to create a holistic picture of clientele background and the makeup. Next is our measures. We will be using the Client Interpersonal Characteristics Rating Scale, or the CICRS. When using this assessment, an observer will spectate a therapy session and notes interpersonal characteristics of the interactions between the therapist and client, which you can see listed on the right hand of this slide. The therapist marks any category's negative sub-behaviors displayed by the client in session. The purpose of the CICRS is to educate the therapist on how clients respond to interactions and how to best implement IRM mode use. This rating scale has currently not been studied extensively, and we hope to learn more about it through our research. Next is our procedures. We plan to conduct a retrospective review and analysis of recorded telehealth intervention sessions. We will analyze at least 30 videos with 3 sessions from 10 different client participants. Our team has an expert on the intentional relationship model, Dr. Popova, training us on how to best locate interpersonal events in the videos on behalf of the client participant. We are also ensuring inter-rater reliability by planning to all watch the same videos and label interpersonal events we see the client exhibit. This is done to make sure our findings are consistent with no rater bias. We have obtained IRB approval, and informed consent was obtained also from the participants prior to our data analysis. So next, we'll talk about our data analysis process. We will be analyzing pre-recorded telehealth sessions using the CICRS that we discussed on the last slide. While watching the videos of the therapy sessions, we will check off any negative behaviors from the CICRS categories that we observe the client doing. We will then use descriptive statistics to look at the client's scores across the various therapy sessions to note any trends, such as whether they improve or stay consistent across time. And lastly, we have predicted some difficulties along the way and also prepared some possible solutions. One predicted difficulty we foresee involves concerns around being in separate regions of the country during our data analysis stage. In order to avoid any issues around working as a team remotely and in different time zones, we plan to set up consistent team meeting times to review data together via video teleconferencing. This will ensure consistent progress in data collection, as well as avoid any miscommunications that could arise while working remotely. Another possible problem is not obtaining inter-rater reliability among our scores. We hope to prevent this by planning to repeat the group scoring process if needed. Team members who are new to video coding and data collecting may experience challenges with staying focused for the duration of the video session recording and noting all of the interpersonal important events. To prevent this, we will each create an appropriate atmosphere to use during our scheduled group coding sessions that promotes efficient data collection and maximizes time spent reviewing videos. There is also the possibility of exhibiting bias during this data collection process. To reduce any bias, we plan to compile a tip sheet to have available during sessions. We also plan to review our scoring guidelines before the data collection process starts. Thank you so much for listening to our presentation.